are now going to move on to our panel discussion, most of which is right here, questions that were submitted by you. Want to reiterate what Dr. Slayman said a bit ago, and that is that we're not going to attempt to diagnose anybody or provide specific treatment recommendations tonight. We're going to try to give your questions to the person whose expertise it most closely matches, and if we have a rebuttal or something else that another panelist wants to add, we will certainly hear from them, but we want to just ask our panelists to make the answers as brief as we possibly can. And the good news is we're going to have dessert at the end of the panel discussion. And not only will you be able to enjoy dessert, you'll also be able to grab one of the panelists here to ask your questions in person if we don't get quite specific enough or get to your question tonight. The first one is for Dr. Ashuri here. We heard Dr. Slayman talk about the importance of clinical trials for things like Herceptin. A member of our audience wants to know how you find out about clinical trials, which ones are available, and whether or not you qualify.
So not too far long ago, it was actually, and still some places, it's still, you need to get down into downtown, get into one of the ivory institutions like UCLA in Westwood in order to get exposed to these clinical trials and see if you qualify to participate. Because of the work of Dr. Glaspie and Dr. Slayman, we brought those clinical trials to our community. So at this point, if you do have an oncologist that participates in clinical trials, the best method is to actually sit down, talk to your oncologist, especially before you undergo any new sorts of treatment or second or third line treatments, and see if you actually do qualify for a clinical trial with a novel agent that could be one of those home runs in your tumor type. There's a lot of things to discuss when you see your physician about clinical trials, things like if it's phase 1, phase 2, phase 3 trial, and then you also have to go through a whole list of things to see if you qualify in terms of inclusion and exclusion criteria. So rather than sitting on the internet and trying to figure it out, it's always best to actually sit down with your oncologist and go through that together.
Okay, next here for Jody Tompkins, who I believe is the only non-medical doctor researcher on the panel tonight, but works a lot with cancer support in the community. Somebody wants to know, is there any scientific evidence confirming the benefits of having psychotherapy while going through cancer treatment?
Yes, thank you. Actually, the College of Surgeons has required that any accredited cancer center has psychosocial support. So that wouldn't be required by medical doctors as part of your cancer treatment if there wasn't quite a bit of evidence that shows that it's beneficial. You asked specifically about psychotherapy, and I'd like to broaden that because really what the evidence shows is that a number of different psychosocial supports help with your immune system and help with people to live longer and recover better. And that includes not only psychotherapy, but support groups and community building and reducing unwanted aloneness. So there's a number of different things that qualify for that.
Okay, back to some medical questions here. We saw that dramatic slide about the prevalence of lung cancer deaths earlier. This one's for Dr. Cohen. The question is, do you recommend that past heavy smokers get a lung CT scan?
Well, if you asked this question about a couple years ago, the answer would be no. For about the last 20 years, they've been doing research on doing annual chest x-rays in frequent smokers or former smokers, and there's never been a significant benefit to detecting the cancer early. However, in the last 2 years, there's been a large collaborative randomized trial that was put on by the National Cancer Institute that has actually showed that if you meet these criteria, that doing annual screening with a low radiation dose CT scan can actually improve your cancer outcome for lung cancer by 20%. And that's if you fit some strict criteria. You have a 30-pack year history of smoking, you're between the ages of 55 and 70, say, and you've recently quit or are still smoker. So at this point, I would say the major organizations like the American Cancer Society, the American Society of Clinical Oncology, the American College of Chest Physicians are all recommending screening with the low-dose radiation CT scan for patients who meet this criteria.
Question here for Dr. Miller, and the question is, has radiation therapy made technological advances in the last few years, and if so, in what ways?
Have you got 2 or 3 hours?
2 or 3 minutes, maybe?
Sure. Actually, before I answer that, I want to give credit to our 2 speakers. I've had the good fortune to work with Dr. Glaspie and Dr. Slayman for over 20 years. And sometimes you don't appreciate the things that are around you. Our community has a large company called Amgen. Part of the foundation of their work is based on work that Dr. Glaspie has done, and it's kind of behind the scenes. And essentially, Dr. Slayman showed a slide where chemotherapy had improved the survival, dramatically improved survival of patients over the last generation. There was a lot of toxicity with those drugs, and Dr. Glaspie's work basically allowed those drugs to be delivered safely so that people would survive the treatment and also survive the cancer. So Dr. Glaspie gets a lot of credit for that, and he doesn't get much praise for that. Saving the best for last, though. Dr. Slayman, his work, he's long overdue to get his Nobel Prize, and I hope it's soon. His work with the HER2/neu basically started the whole notion of targeted therapy. And I had the very good fortune early on when he had some good educated guesses, but we were trying to test it, see what it worked. We were able to work with him, with patients from this community in the early 1990s, trying to figure out what it was that he had developed. And fortunately, many of those people who were, if you will, the guinea pigs back then, they're still alive, and they wouldn't have been otherwise. And so hopefully Dr. Slayman will get his Nobel Prize. It's just long overdue.
Let's hope so.
So back to your basic question. Radiation is a very, very potent tool that's quite capable of killing cancer. And quite honestly, we know that if you give enough radiation, you can kill anything. And I mean, we've fought wars and demonstrated that. But in a simple term, if you give enough aspirin, you can kill yourself. But if you take it in a very measured dose, you can save lives. So radiation used in low doses in a very targeted fashion is quite capable of killing cancer. And when used appropriately, it can selectively kill cancer. And again, if we spread it out, we can take advantage of what Dr. Slayman was talking about, the genetics of the cells. Now, you heard about cells repairing damage. We've been taking advantage of that for years with radiation. Radiation will cause a small amount of genetic damage that the healthy cells can repair, and the cancer cells are incapable of repairing, and we can selectively kill cancer cells. So the trick is get it where it needs to be without putting it in areas where you don't need it. And computers have gone a long way to allow us to improve our targeting. I'm an engineer by training, so this is an absolute perfect place for me to be. This is, the computers and the technology have allowed us to get in and use very smart weapons to deliver where it needs to be. The terms you'll hear in the press is something called IMRT or IGRT, and those are the tools we use. We've actually just added the latest generation of technology for both treating most of the bodies called TrueBeam, and then there's another machine that's called Gamma Knife. And so in terms of technology, there's nothing outside of this community that actually matches what we've got right now.
We have, bringing us back to breast cancer, a couple of questions here. Maybe we can combine them into one for Dr. Malinik here. One person wants to know, says, I would like to do everything I can in the way of preventive cancer screenings, mammograms, and colonoscopies are obvious. What else should I be doing? And then another question specifically about what the best screening would be or treatment for someone diagnosed with the BRCA1 gene mutation.
Okay, so I'll take the second one first. As far as the BRCA gene is concerned, the BRCA gene, as far as women's imagers are concerned, she would be considered high risk just for that. And because she's high risk, there's a much higher chance of developing cancer. There's 2 types. If it's type 1, it's somewhere between 60 and 80% chance of eventually developing breast cancer. And if it's type 2, it's around 35 to 45%. So you're going to need some sort of additional screening. You're going to need your mammogram and ultrasound, and on top of that, you're going to have to add something advanced, and it's usually going to be MRI. A lot of people think that the MRI will take over for the mammogram and ultrasound, but you need all 3 because there's certain cancers that only are detected by mammograms, and there's certain cancers that are not detected well by any of them, actually. So you want all 3, and that gives you your best chance of detecting some sort of small cancer. On top of that, you're going to start earlier. You're going to start usually around age 30. And on top of that, you're going to stagger your exams. So let's say you get a mammogram and an ultrasound. 6 months later, you'll get your MRI. Then 6 months later after that, you're going to get another mammogram and ultrasound. So basically, you're going to get some sort of imaging exam every 6 months. But what we're seeing more and more lately is when people have the BRCA gene, is that, as Angelina Jolie famously and publicly decided to do, is prophylactic mastectomies, which you can see a lot more and more in that. But that's a very personal decision, and it deserves a long conversation with your doctor before that decision is made. The second one was just new screening exams. Is that
Screening
correct?
exams, yeah, outside of mammograms and colonoscopies, what should people be doing regularly?
Well, should be people. There are a lot of new technologies that we're working on right now. In particular, I think the one that's going to be the biggest impact in the future is prostate screening. Prostate cancer is one of the biggest killers of men every year. And right now, you know, in the past we haven't had a good way to non-invasively image the prostate. Now with prostate MRI, we have a real good way to evaluate for very, very small cancers in the prostate gland. In the past, the main way to evaluate the prostate was with a ultrasound probe. And now with MRI, we can not only detect much smaller cancers, but we can also evaluate the blood flow throughout the prostate, which we couldn't do with the ultrasound very well. On top of that, in the past, the ultrasound examination was how we biopsied the prostate, and the way they would do that was that they would go in there and just somewhat randomly pick a section and do about 12 to 16 biopsies in kind of a random order, hoping to get the diagnosis. Now with the MRI, we can really pinpoint 1 or 2 millimeter sized areas and get the diagnosis. Right now, we're doing about 50 MRIs a month. About a year ago, it was only about 3 a month, and so this is going to really take off. We're excited about it. Our prostate guys are always saying that men need to know how to fight like a woman. And so that's our goal, is to make this kind of like how we deal with breasts. And on top of that, the lung cancer screening exam is another avenue of screening that I think we're going to see a lot more of.
All right, let's head back to Dr. Glaspie for this one. The question is, why isn't there more work on recurrent triple-negative breast cancer? And if you can recommend what centers are likely to be doing clinical trials.
Well, there's a lot of work. It's just hasn't been fruitful, right? I mean, everybody knows it's the toughest part of breast cancer. It's where everybody wants to work. There are some new advances that have been put forward at the basic science level that give us hope that you're going to see some very productive clinical trials in the not too distant future. In general, the best clinical trials happen at big centers that are committed to translational research. In this region, it's UCLA. I'm not saying that because I'm at UCLA. It's just I'm at UCLA because I believe that. It's the other way around. But there are several places around the country that are very focused on getting stuff from the laboratory to the bedside quickly.
This one's for Dr. Ashuri. Someone would like to know more about pancreatic cancer. Are there any new treatments on the horizon? What are the newest advances?
So pancreatic cancer is, again, one of those where I still think we're in that one-size-fits-all mode, but hopefully soon it's changing. There have been a couple advancements in the last year and a half with 2 new regimens that we use that we have improved the numbers with. However, like Dr. Glaspie just said, we need to really rely on our scientists in the translational labs to find us these new pathways and to find us these new targets for us to use in our clinical trials out in the community, so we could finally discover what, just like we did with the breast cancer story, figure out what we need to target and how we could subdivide this cancer into a more treatable disease.
Jody, back to you. Ready? Someone wants to know, is there any platform where we can share our personal cancer experiences to give positive attitude reinforcement to people currently suffering cancer?
Okay. So where can people share their story and help others?
Yeah,
Okay.
could you talk about community resources where people may be able to get together?
Absolutely. Translating that into English, since I'm the doctor on the panel here. There are many different platforms to share your story. And of course, I'm going to talk to you a little bit about Cancer Support Community because that's where I work. And we're an organization that's all over Ventura County and also in the San Fernando Valley. We provide the opportunity for people to come together and share their stories with one another and support one another to go through this journey so they're not alone. And it's amazing what a difference that makes. And what we find is that our participants come in, they join support groups, they do yoga together, they come for a meal, they do Tai Chi, they do a number of different things to join together. They're not alone in this journey. And we work with kids, when we work with people who are actually going through cancer treatment and after their treatment, and family members. And a lot of people find that during that journey and afterwards, they want to give back and they want to talk to other people. So they volunteer at our organization. I have somebody I'm looking at right now who's part of our Speakers Bureau, who's here to answer questions for you, to give back to the community. And I think people find that they live a better quality of life when they have the opportunity to share with others and impact others and make their life fruitful. So there's a number of different places they can do that, yeah.
Let's get back to some of the science here. Dr. Glaspie, someone wants to know, since the completion of the Human Genome Mapping Project, what new discoveries have been made related to cancer, and if it could lead to early detection or other kinds of treatments?
I don't know of anything that's come out of that yet that merits the amount of resources that were poured into it. But it does provide us with a tool for anybody who wants to use it that tells you when you're doing research, you don't have to go to the trouble of figuring out what you have. You can log on to the internet and figure out what gene you're dealing with very quickly. And people look at the data that come out of there to try to generate ideas. But it's not, simply having billions of bits of information isn't the key here. The key here is figuring out if you look at a really good business person, they go to the one line of the spreadsheet in 2 seconds and say, that's it. That's what we need, is the tools to allow us to do that, because otherwise there's way too much information and it's really hard to sort through.
There's an interesting statistic, Dr. Cohen, and someone asks, I've heard that Ventura County has a higher incidence of breast cancer than the rest of California. Do we understand why?
I don't think that we know why. There was an article in the Ventura Star, and I was only made aware of this by one of my patients, but there is a higher incidence of Ventura, actually in 4 areas of California that have about 10 to 20% higher incidence of breast cancer than the rest of California. And the study wasn't set up, it was just a documentation study, a registration study, so it wasn't set up to define what the characteristics were that caused that. However, there's some socio-demographic features that are common to all those areas. There are areas such as the North and South Bay in San Francisco, Ventura County, and south near Riverside area as well. And these 4 areas share some features or common features in the socioeconomic factors and demographic factors that are also associated with risk factors for breast cancer. There's a higher percentage of white women, and we know that breast cancer, a certain portion of breast cancer occurs more frequently in white women, in women of higher socioeconomic class, and that's maybe because they had more exposure to estrogen in their life. They were better nourished, so they underwent menses at an early age, or they had children later, or they went through menopause at a later age. And then when they did go through menopause, they were probably more likely to take hormone replacement therapy. Maybe it's some of these factors that are contributing to this increased incidence, but we don't really know.